All right. So I am Carly Prohaska. I am the Dementia Care Specialist at the Aging and Disability Resource Center. And today I'm going to be kind of the narrator of how all of this, and then I will be filling in for the skilled nursing home stuff. So again, if you have any questions, don't hesitate to unmute yourself and then ask. But we're first up going to have the clinic. So that is Clarissa Simonson. So I will turn it over to Clarissa.
Hello, my name is Clarissa Simonson. I'm a nurse practitioner for Ascension Internal Medicine. The clinic portion is important for caregivers in the fact that this is where you first get diagnosed with dementia. We look at treatments for dementia. Also, it's where we start giving the referrals to all the other steps on this roadmap. A lot of times families come to me because they have no idea where to start. And my first suggestion is going to the ADRC to get help. Also at the clinic, I refer to physical therapy, occupational therapy, speech therapy. Most people don't realize that speech therapy really helps with memory. They work with the client with dementia and the caregivers as well for different activities that can help with memory. They also different skill sets too. They help you find ways to cope with your memory impairment. So a lot of times it's not even just the caregivers, but it's the person with dementia themselves too. We help them cope with their memory impairment and how to still be successful in everyday life with this. There are medications that we use too to help with dementia. None of the medications stop any of the loss or bring back any of the loss that you've already had, but they can help slow this down. Hopefully in the future, we'll have medications that can reverse, but at this point we don't. We also rule out different causes for dementia and diagnose different types of dementia. We help rule out any other medical conditions that could be making the memory worse as well, and treatment for that.
And I think another thing to add, the reason the clinic is kind of your first stop in your roadmap is a lot of times people will ask, well, I'm not sick. I usually don't go to the doctor very often. And especially in like the dementia world, the reason people go to the doctor every year is so they have a baseline to compare. So if something changes this year, at least they can compare it to the year prior. Instead of, if they haven't gone to the doctor for 15 years, it's hard to kind of see, where things started, what could potentially trigger that. So that's the importance of the clinic, is just establishing with the primary, even though you may not be, somebody who's super healthy or not healthy, whatever your certain circumstance is, it's nice to have somebody established so they can follow you through your care. And like Clarissa had mentioned, then they're able to refer you to the appropriate people instead of trying to find somebody and then you're getting bounced around and then you feel like nobody kind of understands your care. So that is the importance of the clinic. Does anybody have any questions as far as the clinic portion or the importance of establishing with a primary physician? No questions? Okay, so we're going to move on now to the ADRC, and we'll turn it over to Tanya Simmons.
Hi, everybody. My name is Tanya Simmons, and I'm the Caregiver Services Manager at the Aging and Disability Resource Center. I will be representing the ADRC on this roadmap. The ADRC is an important stop to make regardless of where you're at in your caregiving journey. It's never too late to contact us. Just make the phone call. You don't even have to know exactly what to ask. The receptionist will ask you a few questions and help guide you to the appropriate person. Your call may be directed initially to an information and assistance specialist in the resource center. They'll help you prioritize and narrow down service needs. They're also available to begin discussing long-term care needs and/or in-home supports. For an example, we offer a chore provider list. It's a list of names and phone numbers of caregivers in our community, in our county actually, who share with us different tasks they're willing to help people with. So we maintain that list here. You just need to call and talk it through with an INA staff person, and they will be happy to get you that list. Or maybe it's just you're just in need of some supplies. We have a loan closet here that people donate wheelchairs and crutches and a variety of items that we loan to people indefinitely. So it's free. And a lot of people don't know that we offer that, but sometimes these in-home supports are just what a caregiver needs to help them until the next step or next pit stop in the roadmap, comes along. We also offer here at the ADRC our elder benefits specialists. They handle our Medicare Part D enrollments, and our disability benefit specialists who handle Social Security disability applications. Oftentimes people think that they need to just reach out to an attorney right off the bat, and that's not always the case. I mean, there are free services to help people initially. If an attorney, if there's a complicated situation, we absolutely will recommend that. But a lot of people can start and finish their elder law or planning right here within our building. The Senior Center offers activities and classes and evidence-based health programs. We have a nutrition program that offers home-delivered meals, liquid nutritional supplements, and congregate dining sites throughout the county. Hopefully, we'll be opening those soon. Through our RSVP program, or Retired Senior and Volunteer Program, there are many volunteer opportunities available, including foster grandparent opportunities. A lot of you have heard of the foster grandparent program. Circling back to meeting caregiver needs, the caregiver services manager, myself, I work closely with our dementia care specialist, Carly, our narrator, and our adult day center supervisor. So we have an adult day center in this building as well. We're very fortunate for that. The DCS is available to conduct memory screens and registrations for, there are several wanderers and safety programs available in our county, and she can help with that too. Also coaching families. She's our dementia expert. She can talk through disease specific trials with you. And then also, we do internal referrals back and forth. Sometimes, you might need to have a conversation with the dementia care specialist, and then maybe she knows that, you need to finish a couple steps with an information and assistance specialist. It's really nice that we all get to sort of know your situation, and then we can help guide you once you begin services here within our building. Together, Carly and I, we facilitate 3 caregiver support groups every month. And then we also do teach an evidence-based class called Powerful Tools for Caregivers. It helps caregivers identify their own needs. So, oftentimes as a caregiver, you're asked about the person you're caring for. This class truly focuses on helping you prioritize and work through things such as family dynamics, different stressors that are going on, maybe helping you identify even the smallest of goals so that you can still accomplish some of the things that are important to you. So that's what that evidence-based class is about. And then the Adult Day Center is a licensed day service, and it's available to people on a full-time Monday through Friday, or a drop-in basis. One day a week you have errands to run and you just need a safe place to bring somebody. It's a nice social environment full of activities, and lunch is provided as well. So any of us can help answer questions regarding that. So again, we are so fortunate in Portage County to be able to offer all of these services under one roof. Not all counties have this exact setup like we do. So I don't think I'm missing anything. Carly, do you?
I don't think so. And kind of, I mean, the ADRC, we can talk about it a lot. And we actually are doing a presentation November 30th. I'll send that flyer with this roadmap as well. And what we're doing is essentially a virtual tour of the ADRC and how each department benefits caregivers. That has been a question that has been brought up. So that will be a presentation where you'll extensively be able to ask each department how they benefit you as a caregiver and what service is available that you might not know of. But that's kind of the ADRC in a nutshell. So any questions for Tanya or myself about the ADRC or caregiver specific services available? All right. So next we'll go to home care and we will turn it over to Stephanie Inman.
Hello, everyone. Like Carly said, I'm Stephanie with Compassus. I represent hospice, but I used to do home health, so I'm going to talk a little bit about that and some supportive care today. And I apologize, I have my dog who keeps jumping up on my desk, so that's why I've been going on and off video because he's driving me crazy. So I'm sorry. You can see his little face pop up and down. Anywho, so through Compassus, so just a little history real quick too. So for those of you who are like, who's Compassus? So we were formerly Ascension at Home, and then before that we were Ministry Home Care. So our agency has been around in the Stevens Point and surrounding areas for many, many years. So we have a little bit of a different name, but same care, same support. So not really much is totally different there. So with that out of the way, so home health offers patients and families the ability to recover from surgeries or serious illness in their home. So that can be at their physical home, an assisted living facility, an adult family home, things like that. Patients need to be homebound in order to receive home health services that might be seen as like restrictive, but home health really, if it's a reasonable and taxing effort for you to leave your home, you could be considered homebound. So, you know, if it's a lot of work for you to take your loved one to the clinic to receive therapy, or to like a hospital site to receive therapy, and you're maybe going like 2 to 3 times a week, it might be difficult, the task of getting into the car, getting them ready, getting to the place, getting out of the car, walking to the clinic, and they're short of breath and they need to recover, or it's just a lot. All of those tasks add up, and they need a day to recover as a result of going out to the clinic for therapy. Home health might be an option. So at home, we provide skilled nurses, again, physical therapy, occupational therapy. We have speech language pathology therapy, like Clarissa mentioned, that again come right to the home. We also do have some CNAs or caregivers that can come. Home health is a service that's paid for typically by Medicare, and it's paid at 100%. So they receive that home health services. It's meant to be like a short-term thing typically, to again keep you at home, help recovering from illnesses. A lot of times patients who need some home health services, maybe have been in the hospital recently and they've had an exacerbation of something. So they have congestive heart failure and they ended up in the hospital, and so they need some therapy to help them recover from that difficult time that they were having with that disease. But the nurses can help manage, medication changes, work with their primary care provider. So again, another reason why it's important to visit that clinic pit stop, to help make adjustments in medications so they can stay home. So home health does require you to have a physician or a nurse practitioner who follows you for those things, because again, they need to have someone help make adjustments and medications and kind of oversee that plan of care for home health services. Like I said, it's meant to be kind of a short-term thing. There are sometimes where the home health nurses come in for longer periods of time. Sometimes patients who have wounds, have Foley catheters that need to be changed routinely. That can be done in the home. Otherwise, typically, you know, they can draw labs. They can monitor the vital signs, help with management of other types of tubes and drains. I won't go into details there, but help with, you know, changing incision site wounds and things like that, just to make sure that things aren't getting infected. There's also social workers, that can come out with home health, and they can help with different things too, you know, just kind of having some of those conversations about goals of care, talking about code status, and, you know, looking to see if there's any additional resources that we can bring into the home. So if you miss the ADRC pit stop, then potentially, you know, they may say, hey, go visit the ADRC, or have someone come out to your home, or give them a call so that you can talk about what services you may benefit from as well. Yeah, so that's kind of home health, which is different than supportive care. So I'm just going to mention that real quick. Supportive care is, you know, so there is different agencies within the community, but I think it was Tanya who mentioned they do have some lists of pre-screened caregivers that that would potentially fall into that supportive care. So supportive care is typically not skilled support that comes into your home. So it might be a CNA who you need help with, you know, getting dressed or bathed, or you need help with for your loved one to do those things. But then they can also help with, you know, some light cleaning and doing different things like that around your home. So there is a couple agencies in our area. Synergy Home Care is the one that I'm the most familiar with. I'm not sure if there's really even any other ones in the area anymore, but again, check your ADRC. They can help you. So, yeah, does anyone have any specific questions? That's kind of a general overview of home health. I think there is some information that the ADRC has there about the different services, because there is a couple other agencies that do provide skilled home care in the area. But
it looks like Judy has a question. So Judy, you can go ahead and unmute yourself.
Okay, thank you. I may be getting ahead of myself, but I'm not quite sure where this falls on the roadmap. But I have a friend who is in an assisted living center, but the facility does not provide certain care that she needs. And so there are people who come in to do some skilled care with her.
Yep.
And is that part of this home care or not?
Yep. So home health can go basically to an assisted living facility. They can go to a home. They cannot go to a skilled nursing facility because the level of care that you receive at a skilled nursing facility is, you know, you're going to receive that support daily. So our home health teams can't go into the nursing homes, but yes, they definitely go into an assisted living and help almost to some ways supplement the care that patients receive at assisted living facilities, because like you said, a lot of assisted livings don't have nurses that actually are physically in the building. So our nurses can help with some of those more skilled tasks. Again, wound care, you know, Foley changes. They can help with medication management within the facilities too. So does that answer your question, Judy?
Yes, it did. Thank you very much.
You're welcome. I feel like your guys are giving me high fives when I see the little thing go up. So sorry, Tanya, go ahead.
Okay, well, I just wanted to add before we get too much further down this road, those of us on the panel, we're so familiar with this verbiage that we're throwing out there. And so on the back side of the roadmap, we do have definitions listed, you know, differences between skilled nursing facility and the assisted living, you know, just sort of to represent that there are a lot of different levels or stages of supports that we can put into place before we head all the way down to the end of the road.
And as you can see too, thank you so much for pointing that out, because I think that is helpful. Sometimes we forget about all of the different things, the ways we talk. So I appreciate you saying that. And I think one of the reasons why we made the roadmap a little curvy is that it's not just a straight path. So like I said before, home health may get involved, but they may say, oh, you might need to go see your primary care provider, or hey, have you gone to the ADRC? And vice versa. When someone goes into a skilled nursing home, they may leave the nursing home and then need home health services, or hospice, or that might trigger an event for them to go visit someone for estate planning, things like that. So it's definitely a winding road, and I wish it was straight and narrow, but it's certainly not always. So.
And I think a question that we get asked a lot in our support groups, or even just one-on-one with caregivers, is if they thought that they would be a candidate for home care, and I guess this can be a question for you, Stephanie, or Clarissa, or both. Is this something that they can bring up to their primary and say, I'm having problems with this, this, and this? Do they need a referral to that, or what does that look like? Because I know that's something that's kind of a question that comes up.
Yeah, good question. So, and Clarissa certainly can jump in. I mean, It doesn't necessarily require a referral from your primary care provider. They do need to be involved, and they will be made aware of the referral. But say, if you're at home and someone's like, hey, did you check with that? My first suggestion would always be to call your primary care doctor, just to be like, hey, because they may say, well, maybe we need to do something different. Maybe this medication's not working, and they may have other suggestions too, in addition to potentially bringing in home health. But I would say that would be a good step. If they live in an assisted living facility or a care facility, the facility themselves may initiate the home health referral. Again, we're not going to do any of that without the primary care provider being aware, because they're going to have to agree to follow. So.
Yeah, and I do refer a lot to home health care for people at home, as well as if they're living in an assisted living facility too. Those are good support services, not only for the caregiver at home, but also for the assisted livings, because like Stephanie said, the people at these facilities are not medical staff. A lot of them are CNAs at the most, and some of them aren't even that. So by having a home health care nurse coming in once a week to do dressing, or even multiple times a week to do dressing changes, manage Foley catheters, all that stuff, it really helps prevent any infections. It promotes healing, and also the staff at those facilities then get extra training too from the home health care nurse as well. And when they coordinate that care, it just gives it's just a better situation for that resident too. And even with the families at home, the nurses really do a lot of education and teaching.
Yes, thank you for that.
Thank you both. Any other questions regarding home care? Again, if a question comes up, while we get towards the end, you can obviously answer or ask those questions, and we will answer those as we go. So we'll go to the next stop, which is planning services. We did have a real estate agent that was going to be on, but she wasn't able to make it. So we're going to we're just going to have Penny cover this stop and take it away.
All right. Thanks, Carly. Thank you, everyone, for joining us today. My name is Penny Dupuy, and I am an advanced care planning coordinator at Marshville Clinic Health System. And the advanced planning that I will be talking about today is related specifically to healthcare. And it's taking the time to think about the type of medical care you would or would not want to receive in the event there comes a time when you're not able to make your own medical decisions. And the final product of that thinking and planning is a power of attorney for healthcare document, or an advance directive. I'm not sure how many of you are familiar with advance directives, but a power of attorney for healthcare document is a legal document that allows you the opportunity to state who it is that you want to make medical decisions for you in the event you're not able to make them, and for you to outline what your wishes are in that document and the conversations that you have with that legal decision maker. And that person, that when I talk about legal decision maker, the technical term for that is a healthcare agent. So you may hear the term healthcare agent or appointing a healthcare agent. That is appointing someone you trust who you know will follow through on the healthcare wishes that you would want to receive. So some things that we ask people to think about, well, let me just back up one step. First of all, a common misconception that people have, especially in the state of Wisconsin, is that our next of kin or our spouse or our children or our parents will be able to make medical decisions for us. They can automatically do that. That is not the case in the state of Wisconsin. If we don't have a power of attorney for healthcare document completed stating who we are giving the authority to make these decisions, potentially your family or your loved ones could end up going to court for a guardian to be appointed to make these decisions if there comes a time when you're not able to do this. So what I'd like to reinforce with people is a lot of times people think that this is simply about, and I shouldn't say simply, it's not a simple topic, but people think that this is something that you do once you reach a certain age or if you have a certain illness. And that's not the case. It's important for everyone over the age of 18 to take time to do this in the state of Wisconsin. Sudden events happen, and it's important to be prepared before the medical crisis arises. So some of the things that we do at Marshville Clinic, we have facilitators who can help you do this. You know, another misconception is people think that you need to go to a lawyer to complete this document, and that is not the case. So we are able to provide that assistance at no cost to you. And things that we will explore with you include, you know, any past experiences that you've had with family or friends who couldn't make their own medical decisions, any spiritual or cultural beliefs or practices that you have that may impact the type of medical care you would or would not want to receive. We'll also explore with you what living well means to you. In other words, what matters most? You know, what is important to you in terms of a quality life, or what living well looks like for you. The other thing I would add to this, and I'm so glad that Clarissa is on the line or on the call too, because this is not only important for your loved ones to know what you want, your doctor needs to know what you want if ever there comes a time when you're not able to make these decisions. And this especially comes into play for people who have a cognitive condition like dementia or Alzheimer's, who have had a stroke, that it impairs a person's memory function. This document can give guidance to your doctor, so they know too what your wishes are and who is going to be making these decisions and who they should be talking to as they're providing care and treatment to you. So I guess my one piece of advice, if you haven't done this already, or if you have, take some time to review your document to make sure that the people you've named as your healthcare agents are still able to serve in that role. And if any of your wishes have changed, if you haven't taken the time to do this, or people you know haven't taken the time to do this, reach out to us. You do not have to be a Marshville Clinic patient. We will provide that assistance to you. We can do this in one of several ways. We have facilitators who can meet with you in person. We can do this over the telephone. We can do this on a virtual platform like we're doing today with Microsoft Teams. And we also offer workshops. So you can join us in a workshop similar to something like this, where we're all having a conversation together, and we will help you complete your power of attorney for healthcare document.
Any questions regarding the healthcare power of attorney document or how to do that? And Penny, could you also put your contact information or who they would contact for that in the chat so they have that as a resource as well?
Absolutely.
Any questions regarding that pit stop? None? Okay, so we're gonna go to the next pit stop, which will be quick. is the skilled nursing home. So I'm just going to briefly talk about kind of the misconceptions of this, and that's kind of where it gets into the jargon of a lot of times people think a nursing home is the standard institutional nursing home, but then they also think that is assisted living, that they're the same thing. So they are very different. And Jim will touch a lot on the assisted living and differences. He's more of the expert than I am. But with a nursing home, this requires 24-hour, 7 days a week nursing care. Whereas in assisted living, they don't have a nurse 24/7 around the clock. That's the big difference. And I think a lot of the misconceptions come from. And so that means people are, because of their condition, they need more than just a CNA to provide. That could be wound care, that could be just vital checks, that could be a certain med. I mean, there's a lot of different variables within that why they would need 24/7 care. And then that gets based on, so where somebody goes as far as skill level gets based on what their provider thinks is appropriate or what a functional screen thinks is appropriate, what their level of care is. So that's the big difference between the nursing home assisted living world. And then also kind of in that skilled nursing section is rehab. So again, rehab, when you're coming out of a surgery, you need the 24/7 nursing care for a very short time, but that's the kind of facility you're put in because of the staffing ratio differences, because of the LPNs on staff and the RNs on staff on every single shift. Whereas in the assisted living, they have a nurse that comes in certain amount of hours per week, but isn't there 24/7 for people to consult with. So that's, again, the quick version of the skilled nursing side. But in the name, it says, with the skilled nursing. So that sometimes with nursing home, just think that it's 24/7 nursing care. So that means there's going to be a nurse there around the clock due to the needs of the specific resident and or patient, depending on the facility type. Any questions regarding the skilled nursing side? Or Clarissa or anybody, if you have anything to add as far as the nursing home side. Cindy just wasn't able to attend today, so I was like, well, I can do a quick version as far as differences. Anything that I missed that's important as far as separating the two?
I think you did a good job, Carly. I think the one thing that I would just mention, again, kind of you touched on, is that rehab center is nursing homes right now are really focusing heavily on that short-term rehab and then really working to get patients to that appropriate level of care. So, most patients don't require 24/7 skilled nursing services at a skilled nursing home. So they're really looking at that appropriate level of care for patients.
Perfect, thank you. So then now moving on to the next pit stop, assisted living. So Jim is going to cover that. So we will turn it over to Jim.
Yes, thank you very much, Carly. I appreciate it. And before I start, I just want to, if anyone on here is a veteran or a loved one of a veteran or knows a veteran, just want to say thank you for protecting us. It's greatly appreciated. So with that being said, my name is Jim Miklish. I'm the Director of Community Relations at the Lodge at Whispering Pines and Whispering Pines and Plover. I will say the county of Portage County is very fortunate because there are so many wonderful communities throughout Portage County. They're very fortunate. I think one of the things I'd like to first talk about is, who comes into our communities? When is the proper time to come into the communities? And I always say every person comes in at a different stage. We have some people that come in and they're still driving. We have people that come in and are using four-wheelers. One of the things when I work with families, I say during lunch and dinner time in our eating area, the four-wheelers look like Harley Davidsons lined outside a small tavern in the state of Wisconsin because they're very popular in the community. We have people that are in wheelchairs that still propel themselves throughout the community. Then we have people that we have to assist with everything from toileting to showering to dressing, to get them down to our activity area, to get them to our eating area. So the level of care will vary from resident to resident that comes into the community. I think one of the things that when they come in, there's a box or two that are checked. And typically there might be a safety issue going on at home where the loved one has fallen and may have hurt themselves, and knock on wood, they didn't have to go to the hospital for it. Or the level of care where family is doing a lot of the level of care for them, that level of care just gets a little bit too much. It could be for, the level of care. It could be that they're not eating properly. They're not taking medications at the right time. Their hygiene starts slipping a little bit. The house, which is normally very, very tidy, it starts getting a little bit more messy than what it would usually have. And then it comes down to socialization and activity. A lot of the loved ones are at home by themselves. Families are checking in, and they don't have that socialization. They were very social at one time, and then over the course of time, they become a little bit more isolated. So I think as you're starting to looking at coming into a community, an assisted living community, there might be a safety issue, a level of care issue, and maybe the activity and socialization has started going back. Typically in an assisted living community, we do all the cooking for the loved ones, we do all the cleaning for the loved ones, and we do all the laundry for the loved ones. If they still want to do some of those things, they can, but typically that's included in the services right there. We also have a secure community where loved ones are not able just to come and go as they please. It's more, as Penny was talking about, when the power of attorney, the medical power of attorney has been activated, and they're no longer able to make their decisions, they would go to a higher level of care right there. And I apologize, I feel like I'm that bad person. I couldn't figure out how to get on, but just imagine this voice with the looks of George Clooney. That'd give you a good idea who I am.
Oh, Jim, I've missed you.
And then Jim, to kind of put you on the spot, can you briefly talk about the availability option of respite in facilities?
Yes, that's a great question, Carly. So a respite stay typically, at least in our communities, is defined by a 10 to 27 day stay in a community. Lots of times with a respite stay, the family is watching over the loved one. And then, for an example, the family is going to go out of town on vacation. They don't feel comfortable with the loved one staying by themselves. So then they will come into a community for a short-term respite stay where we can care for them. We cook for them, we clean for them. It's just a short-term stay in the community, but it is defined typically 10 to 27 days in our community.
And to kind of talk on that too, that sometimes gives families kind of a taste of what that looks like. And also sometimes families are like, well, maybe this isn't going to work. Then they have that respite stay and realize that their loved one is thriving in that environment. And sometimes that's kind of the push they needed to say, okay, this is, the best fit. And Jim, with your facility specifically, if they're respite stay and then want to kind of come permanent, is there a process? Would they have to then move out to move back in? Or what kind of process does that look like? I guess in a typical facility, if that respite were to stay, obviously if there was an available bed as well.
Yeah, it's really interesting because I would say 8 out of 10 families I work with, the loved one's a little apprehensive of coming in. And so they'll approach it with the family, the loved one saying, let's just come in, try it for, up to, 27 days, 30 days or whatever it may be. And the first 2, 3, 4, 5 days are typically very difficult because, the loved one's been in their home for 50, 60 years. They've done everything by themselves. The generation that we are working with right now have been very fiercely independent their whole life. They've built their own homes. And so to come into a community and ask for assistance is very difficult. But typically what we see in a respite stay is the family would like just to see how the community works. And so if they come in for that short-term stay, they were on vacation, they come back, they take the loved one out, loved one goes back home. But then when it's time to come back into a community, they're very familiar with the community. They feel good about the community, and it makes that transition a lot easier. We do see, however, sometimes that when they're going to come in for that short-term stay, after, about a couple weeks, when someone's cooking for you, when someone's cleaning for you, when someone's doing your laundry for you, they start settling into a very nice routine. And then they realize, like, okay, maybe I do need a little assistance. And then they realize, families get their lives back a little bit. They're always worried about the loved one, but if something happens, we are there for them. And so it makes that transition a little bit easier. I hope that answered the question.
Yes, thank you. Any questions regarding assisted living for Jim? No questions? All right, so we'll move to the last pit stop, which is end of life, and then we'll turn it back to Stephanie.
Hello again. So I kicked my dog out of the room, so sorry about that. So yeah, I'm going to talk a little bit about hospice care. So I've been working with Compasses or Ministry Home Care for the last 6 years. About half of it has been with hospice. So I'm very passionate about this service, but I'll talk a little bit about what that looks like and where we go. Hospice can be done wherever the patients are. So we follow patients and families wherever they go. So we work with patients in their homes. We work with patients in facilities, nursing homes, assisted livings. We do it for short-term stays, so I can touch on the respite options that hospice also has available. And then we do own and operate a hospice house. It's a 12-bed hospice house in Marshfield, Wisconsin. So there's an inpatient unit as well. Thanks, Penny. Hospice is wonderful, she says. So it's really meant to support not only the patient, but their families as they go through the end of life process for someone who's dying. So you have to be eligible for hospice because, of course, it's a Medicare program. So someone is typically eligible if they have a terminal diagnosis, that if the diagnosis runs its normal course, that within 6 months, the expectation is that that person may or may not be with us. Be with us. We work with our hospice medical director and usually the patient's primary care providers. So our medical director through hospice for our agency is Dr. Terry Hahn. She's at the Ascension Medical Group in Stevens Point at Internal Medicine. And then we do work with lots of providers in the community. So we work with Clarissa, as well as other nurse practitioners and providers in the area. So we have nurses, we have social workers, chaplains, we have CNAs or home health aides, or hospice aides, I guess, volunteers, bereavement coordinators, and then we have a nurse practitioner and physicians on our team as well. So they all have a specific role to help patients and families go through this process. It's one of the programs that are truly designed to be collaborative and interdisciplinary. So it's really making sure that not only does the patient get that support, that the loved ones, caregivers, maybe even the staff at the facility, that they're taken care of as well. So there's a lot of different reasons why someone would be eligible for hospice. I won't go through all of that, but the only thing I would say is that if you're wondering whether or not it's something that's appropriate, obviously talking with your doctor is a good step. But really, you can call our company or agency at any time and just ask questions. We can have someone come out and meet with you just to talk about hospice and what that would look like for your family or your loved one, and determine whether or not they may or may not be eligible at this time. There's no cost to that. Hospice is a Medicare benefit, like I said before. Not only does it cover our staff that I spoke about, but we cover medical equipment. So that can include hospital bed, wheelchair, oxygen, basically anything you need. And we don't have to jump through all of the hoops that you would have to potentially otherwise. So if anyone's tried to get a wheelchair or a hospital bed for their loved one, under hospice, we don't have to go through any of those things. We also cover certain medications that are related to the diagnosis for which someone is on hospice. So usually that's a lot of the comfort medications. So sometimes that can be very helpful too for families with cost. I'm sure I'm missing all sorts of stuff, and I just did this talk yesterday, but hospice is meant for basically anyone, like I said, who has that terminal diagnosis. Oftentimes people think, well, I don't need hospice yet. My loved one's not dying. And that very well could be the case, but if you're like, well, I don't want to have much treatment, or I don't want to go back and forth to the hospital, or this is just really hard on my husband and he can't handle that anymore, to be going back and forth to the hospital and get poked and prodded and go through all of this for them to tell me that there's not much more that they can do. Hospice certainly might be an option for them at that point. Again, there's certain criteria that you have to meet, but we look at that. That's not something you have to do. So it's not necessarily intended just to be those last couple days of life. So, yes, Tanya.
So I just like to always mention, we had a great experience when my dad was on hospice, which was for almost a year.
Mm-hmm.
And it's a misconception out there. Oftentimes we think that when we hear somebody is on hospice that, they have 2 weeks to live or, something like that. But without that support, I mean, we just, like Stephanie had said, wasn't just for my dad, but my goodness, the support we received from the social worker and just talking things through was so helpful. We would have been lost without him.
Yeah, and that's a really good point to bring up, though. And Tanya said, her dad was on for over a year, or right around a year. Like I said, it's that to be eligible, they have to potentially expect that you would pass in those next 6 months. But that doesn't mean that within 6 months, if that hasn't happened, that you come off hospice. We've had patients on hospice. I think 2 years is probably one of the longer patients that I had on, and he got on fairly soon, but he never got better. Things declined for him slowly over a period of time. So yeah, was there another question?
Oh, and just one other pleasant surprise we had during this time was that my mom had a health setback, and she was his primary caregiver. And so we were able to then utilize that respite option actually twice.
Yep.
So we were so thankful for that too.
Yeah. So I see that Judy has another question too, but just real quick to touch on the respite benefit. So hospice does offer a 5-day respite stay for patients. So sometimes, usually that's done in like either a hospital, nursing home, or again, we use our hospice house in Marshfield too for that sometimes. So yeah, a loved one, we had a patient whose wife ended up in the ER, and she needed some time. So we placed her husband in respite for 5 days. She was able to recuperate, get back home. People have gone to weddings, or sometimes they just use it as a little bit of a break. Caregiving is a tough job. We know that. So just knowing that they have the opportunity to have some support, that their loved one's taken care of with that hospice philosophy still is really important and helpful. So.
Right, and Judy, you can go ahead with your question.
Yeah.
Yes, could you please distinguish between palliative care and hospice?
Absolutely. So palliative care is meant for anyone with, and Clarissa still on? Certainly can jump in here too. But yeah, so for hospice care, typically you're no longer seeking curative or aggressive treatments any longer. So for palliative care, you can still seek treatment for your diagnosis, but you get some extra support, whether it be from a nurse practitioner who can potentially visit your home. They do a lot of like what we call goals of care conversations. So they're talking about, and anyone who has a terminal diagnosis can be eligible for palliative care. So that's one thing that I guess I will just mention is you get a diagnosis of let's just say COPD. So you have the lung disease. As soon as you're diagnosed, technically you could be eligible because they know that diagnosis, there's no ultimate cure. They're going to manage it. So as soon as you're eligible, as soon as you're diagnosed, you could be eligible. Most people don't utilize palliative care quite that way because they're not quite ready for that. But you can still seek treatment. So you can go to the hospital. You can have aggressive therapies kind of done. And at some point, you probably will need hospice care, but hospice care isn't for all patients who are receiving palliative care. So again, just let me make this a little bit more simple. So hospice, you have decided you don't want to pursue any more aggressive treatments, and have comfort be the focus. And with palliative care, ultimately you can still be seeking treatment, but they're taking a symptom kind of managed approach to your care. Does that make sense?
Yes, thank you very much.
Yeah.
Along with the palliative care, I know we have a lot of agencies. We're getting more agencies in our community, which is nice. For the assisted living part of it, really, it's not used as much because I go to the assisted livings to see everybody, at least for all my patients. I'm at the assisted livings once a week. So those patients really don't need it. I really practice in a palliative approach at that point anyways.
Right.
But for my patients that are at home and for the caregivers, I do often refer to palliative care because sometimes we can get the nurse practitioner that'll come right to the home and they will visit at least once a month. And it's just another set of eyes to let me know, hey, and that nurse practitioner works with me. We collaborate on what we think is best for whatever's going on at that time. And really it's nice, because when somebody calls and says, well, this is what's going on, but actually having somebody being able to evaluate the loved one is really good too, so that we're not missing anything as well.
Yeah, so what Clarissa's talking about is there's some community-based palliative care programs. I know Heartland Hospice just recently started in our area, and then Interim Healthcare, they're out of Wausau. They have community-based palliative. Our company has a palliative approach to care within our home health agency. That's just a little bit different than what specifically Clarissa is speaking of, but that's obviously, again, different than hospice care is. So.
Perfect. And it looks like Ellie has a question. So Ellie, you can unmute and ask your question.
I wondered, and maybe Penny can help with this, did talk about medical power of attorney, but could you make some comments about the do not resuscitate issue and what kind of a process it would take if you wanted that?
Yeah, that's a good question, Ellie, and I'm actually going to ask Clarissa to chime in too to this question. But there's an opportunity. There's a couple of issues. One, in the power of attorney for healthcare document, you can state in that document whether or not you would want CPR. But that situation only applies to a situation where you're not able to make your own medical decisions and you're in a hospital or a nursing home. Because if you're in one of those types of facilities, they need to know when you're there whether or not to start CPR. There's also what's called a community do not resuscitate bracelet that you can obtain, and that is a healthcare provider's order. So that can be provided by a physician or a nurse practitioner. And you have to meet certain criteria for that. So you have to be have a terminal diagnosis or have a health condition where CPR would be more harmful than helpful to you. And you and your physician need to come into that agreement. And like I said, that is an order and that is applicable in the community. So if something were to occur, if you would have a cardiac event in the community and the ambulance is called and you have that do not resuscitate bracelet, they would not perform CPR. Does that answer your question, Ellie? Or is there anything more you would add, Clarissa?
Yeah, so if you want to obtain one of those bracelets, you just contact the primary care provider, let them know that you want a DNR bracelet, and then usually the providers sign them, not a problem. Especially as you're aging. We use it a lot with dementia, congestive heart failure, COPD, any of those things. Really, on TV, it always looks good. TV, it looks good. CPR works, everybody comes back to life, they're sitting up and they look great. In real life, that's not what happens. In real life, it's a very small percentage, less than 10%, that actually survive after going through CPR. And that percentage goes down as you age and if you have heart conditions or lung conditions. And then if you do survive it, it's usually only within it's usually about 5 days longer that you live. So, just looking at, what people want and having that discussion with your primary care provider too. I've seen different things where people say, don't intubate me, but give me drugs. Don't do chest compressions. But give me the medications and intubate me. And I always like to let people know this, the medication option isn't an option if you're not doing chest compressions. So we do the chest compressions to get the blood to circulate through the body. So it's really important. It's kind of a DNR is an all or nothing kind of deal. We don't really pick and choose what parts of CPR we want done. And you do need to be wearing that bracelet when the ambulance is called. If you are not wearing that bracelet, they will still do CPR. So that's important too. I know a lot of facilities, they put them in their charts, and then as soon as they call an ambulance, they put it on them so that they don't do CPR.
Yeah. The other thing I'm just going to mention, since funeral home is listed underneath of mine, or this particular area, and again, it's one of those things that you should probably do well before you reach hospice care, but people do wait for quite some time sometimes to actually go through the process of planning for that. But a lot of funeral homes do a lot of pre-planning things where you can go in and really talk about what you want or what your loved one might want, and that it's all taken care of. Obviously, that money then doesn't get tied up, and you can potentially apply for additional services since you've set that money aside, because it's usually not looked at as a part of like an asset, quote unquote, when you're applying for Medicaid or different funding sources. So certainly would encourage anyone to be looking at that as well early on in the process, just because it's one less thing that they have to worry about. We've worked with families. I just actually had one last week where the patient died, and it took the family quite a few quite a while to make a decision about a funeral home. And while that's fine, it's just something else that was on their plate at that time that even though we'd been talking to them about it, they, didn't want, it was kind of a denial thing where they were kind of just not ready to talk about it. But then, of course, mom passed away and they had to spend the next, 5 hours trying to figure out which funeral home to utilize. So one other thing I didn't mention with hospice care quite yet is we do offer bereavement services. So that's that grief support. It's offered for 13 months after death. Excuse me, our hospice agency, and I think some of the other ones in the area too, don't require patients to be, or loved ones to have actually been utilizing our hospice agency to be eligible to come to our grief support. So we have different groups, and really just there's mailings and just different information that gets sent out routinely to help families get through those firsts after their loved one has died. So, any other questions?
Any questions regarding end of life or any questions about the whole presentation? So you guys, that's an hour full of a lot of information that we kind of jammed and threw at you. But any questions regarding the roadmap, or maybe a question that you're like, well, what about this service? Where does that fit in? Any questions at all? And like I said, this will be sent out. I will email all that. If there's somebody that was on the panel that you want their contact information, let me know and I can get that to you. Penny did put her contact information regarding the planning services in the chat as well. To see that, there's that circle little chat bubble that has the lines on it. You can get that and you'll scroll up and be able to see her contact information as well. Any last minute things for anybody on the panel that you want to share that maybe you didn't touch on or feel that attendees should know?
Well, Carly, I'm seeing a hand up somewhere. I'm not sure if that's a mistake or if it's just stuck on my screen. I can't tell who.
Ellie, did you still have a question?
No, I just
Okay.
don't know how to take the.
Oh, that's okay.
That's okay. You know what? There are a couple of other things as people were talking that came to mind. We're not trying to overwhelm you, but we know everybody's situation is different. And if just one or two of these things stick, I think we've done our job here, today. But back to the in-home supports, I know it can seem very daunting. Sometimes at first, just getting services aligned, and sometimes it means we are utilizing a chore provider from that caregiver list, and then maybe there is another community, there's an agency out there, a faith-based organization called Deeds Meet Needs that provides some transportation help and a few other things. That's really what we here at the ADRC help with. We help you navigate, and like Carly mentioned with the upcoming presentation, you'll learn more about those things then. But don't let being overwhelmed prevent you from reaching out to us. We try to identify your first emergency or need and get that taken care of. And you know what? It might be just a matter of a day or two or a week. And we might be in touch with you regarding, hey, how about some home delivered meals to help you just take something off your plate for now so that you can feel less stress. And so sometimes it's kind of a building block of services, blocks of services that we help you coordinate. I know what that's like to be given all of these pieces of paper and services and be like, oh my gosh, I'm so overwhelmed. I don't know where to start. And that feels like a bigger project than what I'm dealing with here right in front of me. So, we know that it can work, just putting some of these things into place. Another important thing, when Penny was speaking, it made me think of this. So you as a caregiver, that's the point of National Family Caregiver Month. Again, we care about the people you're caring for, but we are representing you. We need to help you so that you do outlive the person you're caring for. It's blunt, but it's our goal. And we have seen it happen too many times where a caregiver hadn't thought about themselves and put a plan in place. So through the ADRC, we also offer something called the Vital Information Packet. We use acronyms for everything, VIP. We can help you with that too. Again, yes, more paperwork, but it's so important. And it's basically this packet of information that can hang on your refrigerator. All of our response teams in Portage County are familiar with this packet, and we help you fill it out with information about if something happens to you, and say that you are caregiving for somebody who has a dementia. Well, can they call 911, or when 911 arrives, are they able to answer any of their questions? The information is kept in this packet regarding yourself. So maybe you have a pet and you need to say, my next door neighbor will take my pet while I'm in the hospital short term. You know, it kind of gives you peace of mind too, to know that, yeah, I'll be taken care of as well. Somebody is watching out for me too. It's not all about the person I'm caring for. And then one last thing is, so a spinoff of this caregiver roadmap, the state took a look at our roadmap here that I'm so proud to say our Portage County Coalition team put together. And it's in the panel representation that you have here. And it started out just as a conversation, and it kind of morphed into this. There's a need for this tangible piece of paper that just helps us guide a conversation. And the state asked if they could use the model and create what they're calling an after caregiving roadmap. So I know we took you along the curvy roads all the way through the end of life, which isn't fun or easy to talk about. But there is a more cyclical version of this that will be available to everybody soon. Every county has to customize it for their own county. We know that caregiving does not end after a person passes. And we experienced this. My dad passed on May 1st, 2020. And it's at least, like Stephanie mentioned, with the bereavement, a 13-month process. The grieving is different for everybody, and the paperwork and the things you hadn't even thought of that you would need to take care of come to light. And even just things about yourself, finding what you like again. So it's a packet, more than just a roadmap, but a packet of information that's available as well. So I'm really proud of that. And I don't know that I really didn't get to announce that to all of the panel members. Stephanie, I think, knew about it, but so yeah, very proud of that. And we're being used as a model to the rest of the state. But that's really all I had to share.
I was just going to say too, Carly and I get to present this at the Alzheimer's conference. I don't remember when it is now because it's been changing, but yeah. So
it'll be next May, hopefully in person.
Yeah. So yeah, it seems like a long ways away, but it'll be here before we know it. So.
Any last minute questions? Again, I think everybody who is an attendee has my contact information. You will when I send out all of the flyers as well. Feel free to let me know if you have any questions, and I can get you in contact with the panel member that can answer it best. But last minute, any questions or any other statements regarding the roadmap?
I was just going to say it's nice to see everyone's face. Some of you whom I haven't seen in a while. Penny, hear Clarissa's voice, Jim's voice.
Absolutely. Well, we're done obviously early. We just wanted the 2 hours just in case if there was questions, or if we, some of us like to talk a lot, so we didn't know what the time frame would be. But thank you guys for participating. Hopefully it was helpful, and thanks to the panel members who took time out of your day to do the roadmap with us. So again, if you have any questions, just reach out and we will get you in contact with the appropriate person. But enjoy the day, even though it's rainy and gross outside. And hopefully we'll see you at other events this month.
Bye.
Thank you.
Bye,
Thanks,
everyone.
everybody.
Thank you.
Bye-bye.
Thank you, everyone. Bye-bye.